Hey, BC here. Welcome to BC Nephro. Moving on in our dialysis rounding primer series. Today we're going to be talking about nutrition in the dialysis patient. For the complete dialysis rounding primer series, check out the playlist at this YouTube channel. Link will be in the description below. And also check the articles at bcnephro.com. So when I'm rounding on dialysis and addressing nutrition, I'm addressing 5 things. I'm looking at 5 things. First, I'm looking at the albumin. Next, I'm looking at the potassium. Third, I'm looking at the bicarbonate. Fourth, I'm looking at if the patient is on a B complex C dialysis formulation vitamin. And finally, I'm taking a look to see if the patient has diabetes and if we have a blood glucose or a hemoglobin A1C in the labs. So first, albumin. So protein, energy wasting, malnutrition, important in dialysis patients. Dialysis patients are recommended to have 1.2 grams per kilogram of protein per day, which is difficult for these patients to have, and many of the patients don't achieve this. This is one of the reasons why I'm not big on recommending a protein restriction for patients with chronic kidney disease. I think its benefit is limited in most patients with chronic kidney disease. And if you're recommending a 0.6 to 0.8 gram per kilogram protein restriction in chronic kidney disease, and then they're on dialysis, all of a sudden they have to double it. Not used to doing that, difficult to do. Protein supplements are often prescribed in the dialysis unit and at home and are very important. The other thing that makes protein management difficult in dialysis patients is the dialysis procedure itself removes some protein, some amino acids. So you have these patients now who are not used to having high protein. They might be anorexic from uremia when they started dialysis. They may have some other comorbidities, and then removing some of the amino acids with dialysis makes it more difficult to prevent them from having protein energy wasting and being malnourished. Next, I'm looking at the potassium. A couple things I'd like to talk about the potassium. There are different potassium dialysates. So we're talking about standard is usually either 2 potassium or 3 potassium. I typically think if the potassium is less than 4, they should be on a 3 potassium bath. If potassium is greater than 5, they should be on a 2 potassium bath. And if it's in between 4 and 5, just leave them on whatever bath they are. That keeps them there. But a couple things. There are 1 potassium baths available. I discourage it. These are often used with patients who have very high potassium despite a 2 potassium bath. And the rapid potassium shifts there can predispose to arrhythmias. A better way is to continue the 2 potassium bath and extend the dialysis time. And if that doesn't work, add a oral agent to lower it, such as Lokelma. The next thing to know is that since most of the potassium is intracellularly, during dialysis and immediately post-dialysis, the patient will be transiently hypokalemic until the potassium redistributes from the cells to the extracellular space. Don't check the potassium during dialysis or immediately after dialysis, and certainly don't act on it. If you're going to be checking the potassium post-dialysis, wait 4 hours to make treatment decisions. The next thing about this is if there is a patient who's prone to cardiac arrhythmias, on digoxin, some sort of cardiac patient, the transient intradialytic hypokalemia may be an issue. So you might be better off keeping that patient on a 3 potassium bath and allowing mild pre-dialysis hyperkalemia in the low to mid 5 range. Next thing I'm looking at is the serum bicarbonate. Metabolic acidosis is an issue. We also don't want to cause an iatrogenic metabolic alkalosis by using too high a bicarbonate bath. I usually target the bicarbonate to between 22 and 28. If it's above 28, I try to look at, is there a reason why they have a chronic respiratory acidosis, obesity, hypoventilation, and they need that bicarbonate elevation for compensation for the respiratory acidosis? If not, I'm going to lower the bath. The next thing, easy to do, but also easy not to do, to think is not important, is vitamins. Now, water-soluble vitamins, which are the B complex and vitamin C, are washed out during dialysis. So vitamin B1, thiamine deficiency is common, B6 deficiency, B12 deficiency, folate deficiency, and vitamin C deficiency are common. And you're not going to see like scurvy or beriberi or things like this. but there are some associated things with these vitamin deficiencies, including neuropathy with vitamin B6 and vitamin B12 deficiencies. You could have unexplained encephalopathy or heart failure with thiamine, vitamin B1 deficiency. You could have relative iron deficiency with vitamin C deficiency. So there's certainly things that you see in dialysis patients that you might attribute to uremia or their comorbidities, and I really think that we should make sure that we can't help these with a simple prescription of a multivitamin. Other thing to consider, the association with homocystinemia with the vitamin deficiencies. Dialysis patients already at a risk for atherosclerosis, and you're going to want to think about that. Another issue is diabetes. If the patient has diabetes, sometimes an A1C is checked by the dialysis unit, or there's a random glucose with the pre-dialysis monthly labs. So the thing is this, although I don't think it's in our role to actively manage diabetes, we should be counseling the patients on their diabetes status, make sure they're having the appropriate follow-up, and we should be making sure that they're not on medications that are contraindicated or need a dose reduction for dialysis. So those are some of the things to think about when we're addressing the nutrition status on dialysis patients, particularly in outpatient dialysis rounds. If this video was helpful to you, share it with your friends, give it a like. For more information, check out the article in the description below at bcnephro.com, and until next time.